Okay, so this is one of the old cases, and the most important thing here is also to show you the variability and why you need to do the DNA RNA. Frequently, we detect a mutation in the RNA, not in the DNA, and sometimes in the DNA, not in the RNA. It depends on the type of the mutations, and it depends also on the enrichment of the mutant allele. As you know, imprinting is a big thing in cells, and sometimes the imprinting can really involve the wild type allele and allow the expression levels of the of non-imprinted allele to express more, so we can detect a mutation in RNA we don't see in DNA. But this case in particular is the opposite. We detected, for example, the BRCA1 mutations, which is very important. It was detected in the DNA, but we didn't detect it in the RNA at sufficient level to call it. I'll show you in a minute. This is very important mutation because it also leads to early terminations. And some of the early terminations, because the protein is not synthesized, the RNA gets degraded very fast, so you cannot really see it. You cannot really detect it when you do the RNA sequencing. So as you can really see, we detect the mutations in the cell-free DNA, but at extremely low level of the cell-free DNA, as you can see, 0.2% variant allele frequency. This is very important because this implies or means that the BRCA1 mutation is somatic mutation. It is not a germline mutations because it is detected only in the tumor and it is not detected in the cell-free DNA. And all these are very important informations. Patient TMP, as you can see, very high here. And next slide. Next slide. So the next slide shows the summary. Next slide, please. Shows the summary of these findings. So the BRCA1 is a somatic mutation at germline, and there are additional abnormalities. Next slide, please.
Okay.
So Dr.
Right. Okay.
This is a 68-year-old patient who in 2006 had a right mastectomy for an ERPR positive, HER2 positive cancer. She was no evidence of disease until she presented in 2019, 13 years later, with the gastric outlet obstruction. She had surgery and a peritoneal biopsy was done, and she had ERPR positive, HER2 negative breast cancer again. She was treated with aromatase inhibitors and a CDK4/6 inhibitor until she developed a ureteral obstruction. And again, her PET scans are consistently negative, but tissue came back, which is what you're looking at, which shows a high TMB and ERBB2 positive. The tissue is HER2 negative by IHC and FISH, but positive by the GTC next-gen sequencing test of Dr. Albertar. She's currently, because of her high TMB, though MSI is stable, she is on Abraxane and Tecentriq and doing extremely well. We haven't yet introduced anti-HER2 drugs, but we will should she show any signs of progression.
Good. Well, thank you very much. We really appreciate all your input, and thank you so much, Dr. Weintraub. Appreciate it.